All right, let's jump right into a really core topic in orthopedics: axial deformations of the lower extremity. We're going to break down what they are, where they come from, and most importantly, the thinking process behind how we decide to treat them.
So, let's kick things off with the big question, the why behind all of this. We're talking about a leg that's maybe off by just a few degrees. It really doesn't sound like much, does it? So why do we, as surgeons, care so much? Why is this tiny deviation such a massive deal?
Well, here's the answer. And it's all about physics. It's about where the stress goes. Think of it like a tire on your car that's out of alignment. One side of the tread is just going to get worn down way faster. That's exactly what's happening inside the knee joint. This isn't a cosmetic problem. It's a mechanical one that directly causes one side of the knee to wear out. And that's the osteoarthritis we're trying to get ahead of.
Okay, so before we can really talk about what's wrong, we have to lock down what's right. And in orthopedics, that standard is the mechanical axis. Imagine a plumb line for the leg, dropping straight from the center of the hip, right through the ideal center of the knee, and down to the center of the ankle. That's our goal. When that line misses the middle of the knee, well, that's where the trouble starts.
And here they are, the two big players, varus and valgus. Genu varum, which you probably know as bow-legged, is when that mechanical axis falls inside the center of the knee. All that body weight gets funneled right onto the medial or inner compartment. On the flip side, you've got genu valgum, or knock-kneed. Here, the axis swings to the outside, hammering away at the lateral compartment. It's a really simple concept, but over years and millions of steps, the consequences for the joint are huge.
So, where do these deformities even come from? We can pretty much group the causes into two main pathways: things you're born with or that develop as you grow, and things that are acquired later on in life.
Let's break that down. On one side, you have the developmental causes. This can be anything from normal physiologic variants in kids to metabolic diseases that affect bone growth. Then you have the acquired bucket. And here, trauma is a huge player. A fracture that heals in the wrong position, what we call a malunion, is a classic example. Another is an injury to a growth plate that causes it to stop growing prematurely. Knowing which path led to the deformity is absolutely critical for figuring out what to do next.
Now, for those acquired deformities, there's a concept you absolutely have to know: the cora. Think of it as the hinge point of the deformity. It's the geometric apex of the problem. Finding the cora isn't just an academic exercise. It's literally the X that marks the spot for a surgeon. It tells you the exact point where you need to plan your correction to get that mechanical axis straight again.
Okay, so we suspect there's a deformity. How do we prove it and, more importantly, plan for it? Let's walk through the diagnostic game plan.
It's a really solid three-step process. First, you use your eyes and your hands. You watch the patient walk, you check for ligament laxity, you get a feel for the whole clinical picture. Then comes the crucial part. Step 2, full-length standing x-rays. I can't stress this enough. You can't eyeball alignment, and you definitely can't assess it from a small film of just the knee. You need the whole picture, hip to ankle. Only then can you move to step 3, which is getting out the digital protractor and actually doing the math.
And this right here is the language we speak in deformity correction. These acronyms might look like alphabet soup, but they tell a very clear story. The MAD, mechanical axis deviation, tells you how bad the overall problem is. Then, the other joint line angles, like the MLDFA and the MPTA, they're like your detective tools. They let you pinpoint the source of the problem. Is the femur the culprit, or is it the tibia, or maybe both?
All right, we've got our diagnosis, we've got our numbers. Now it's time to figure out what to do. And this is not a cookbook, it's a decision tree with some really important branches coming up.
And here it is, the very first and maybe the most important question you have to ask yourself. Does this patient still have open growth plates? The answer sends you down two completely different treatment paths.
And you can see why. These are two totally different philosophies. If the patient is still growing, we can be really clever about it. We use something called guided growth. It's like putting a tiny brace on just one side of the growth plate. You're not cutting the bone, you're just, well, guiding the growth that's already happening to do the work for you. But once those growth plates close, that ship has sailed. For an adult, the option is a corrective osteotomy. We have to go in, surgically cut the bone, and physically realign it ourselves.
Okay, so let's follow that adult pathway for a second. We hit another major fork in the road. And this one is all about the health of the joint surface itself. We have to ask, what does the cartilage look like? Is there enough healthy joint left to work with, or are we past the point of no return? This is where we make the huge decision between joint preservation and joint replacement. If the arthritis is mostly confined to that one overloaded compartment, we can perform an osteotomy to shift the weight-bearing axis back over to the good side. We're preserving the patient's native knee. For a younger active person, this is a fantastic option. But if the whole joint is shot, if all three compartments are worn out, trying to realign it is like rotating the tires on a totaled car. Joint preservation is off the table, and we're looking at a total knee replacement.
Okay, that was a lot. Let's boil it all down. What are the absolute must-know high-yield points you should take away from this? First up, the fundamentals. Remember, the mechanical axis is king. Varus loads the inside. Valgus loads the outside. And if you let significant malalignment go, you are setting that patient up for early arthritis. It's not a maybe, it's a win.
Next, your diagnostic keys. The single most important tool is that full-length standing X-ray. It is non-negotiable. Then, you have to do the math. Quantify the deformity with your angles. Don't just eyeball it. Figure out exactly how much it's off and where the problem is coming from. Femur, tibia, or both. And finally, the treatment algorithm. It's actually pretty logical. If your patient is still growing, think guided growth. If you have an adult with a pretty healthy joint, think corrective osteotomy. And if you have an adult with a worn-out arthritic joint, you're looking at arthroplasty. It's a clean, evidence-based flowchart.
So I'll leave you with this to think about. We've spent this whole time talking about the coronal-plane. That's the side-to-side varus and valgus. But of course, a leg isn't a 2D drawing. It's a 3D structure. So the real next-level question is, when you make a correction in that one plane, what are the ripple effects? How does fixing the varus change the knee's flexion or the foot's rotation? And that's when you really start to appreciate the complex and fascinating machine we're working with.